Yeah, the last session for the evening, and to moderate the session, may I invite Dr. Abhijit Raha, and may I request the esteemed panelists, Dr. Devi Shankar Dev, Mrs. Shokamisha, and Mrs. Shormishta to join the panelists. So this session is going to be on the pregnancy, nutritional stewardship on pregnancy. So I hand over the podium to Dr. Abhijit Raha for the next case-based discussion. Thank you.
Hello, good evening. Thanks for the lovely attendance on this great Sunday evening. I welcome my co-panelists and I thank Howrah chapter of Critical Care Society to give me this opportunity. So, when we are talking about nutrition stewardship, especially in obstetric patients, there are a number of issues that we face because a pregnant patient is different because of the physiological changes of pregnancy. There is another life involved, a fetus is involved, and there are some conditions which are specific to pregnancy like AFLP, cardiomyopathy, embolism, HELP, eclampsia, preeclampsia, which are again rare conditions that we encounter in day-to-day adult critical care, but we have to be prepared for it because these patients do keep coming up. However, we will not limit our discussion to just critically ill obstetric patients. So I have prepared a case. We got this case some 2 years back in Antago. So before we get into this, before we get into a obstetric patient getting admitted to our unit, I just like to ask our esteemed nutritionist present over here, if we get what do you suggest, what do you advise to a pregnant lady who has come to your clinic, say in the first trimester or the second trimester, right after pregnancy, or she is lactating, what do you suggest?
Well, a pregnant woman, when you come to our clinic, first we recommended calorie more than 350 additional calorie. If the normal calorie requirement is 1800 calorie, in a pregnant woman we added more than 350 calorie during the second and third trimester, and additional protein. Suppose a reference woman, the protein requirement is 55 grams. When the second trimester, we add the protein more than 9 to 10 grams. And the third trimester, we additional the protein requirement up to 23 grams. So there are a few guidelines we suggest to the pregnant mother that frequent milk intake should be advisable. Skipping milk or fasting is not advisable in this case. During pregnancy, constipation is a major problem. So we encourage the mother to intake more of fluids intake during the meal. Should be intake lots of vegetables and fruits, at least 3 to 4 cups of vegetable included in her diet regularly. During pregnancy, calcium requirement is very essential because lack of calcium, osteomalacia is some of patients showing the osteomalacia. So in the case of pregnant mother, we recommended at least 3 glasses of milk every day. If the mother is lactose intolerance or any GI problem, in that case, pregnant mother should take calcium supplement on her diet as per doctor prescribed. Iron is also important because if iron is not maintained, then patient is suffering from the anemia. So iron is iron is also included in her diet. So we included the whole egg, the animal protein also included in the diet. The animal protein like egg, whole egg, fish, meat, adequate amount. Okay, some of patients are suffering gestational hypertension and edema is the common case during pregnancy. So in that case, sodium should be restricted. Caffeine also restricted. 2 cups of coffee is recommended, not more than 2 cups of coffee. And in that case, omega-3 fatty acid included in her diet. So in that case, she can add walnuts, soybean oil included in his diet. During pregnancy, sugar substitute should be avoided because there is a high chance on the second and third trimester gestational diabetes. So we suggest that consumption of sugar as less as possible. during pregnancy, we also suggest to avoid fried item, the fatty item, also the lots of seasoning vegetables, flavored vegetables in the case of nausea and vomiting. There is a basic reason during pregnancy take high calorie, high protein requirement in our daily diet, and also included fiber because constipation is the also main problem during pregnancy. So lots of fruits and vegetables included on her diet in the daily basis. Thank you.
So, could you enlighten us about what is the role of micronutrients, any specific micronutrients other than what you have prescribed, iron and folic acid? Any other micronutrients that we have a recent guideline on? I work in critical care. I don't have much idea about what happens in the OPD based clinic. Any specific guideline about any micronutrients like selenium or zinc? Earlier we used to have guidelines on selenium in pregnancy. So I would like to take the next.
Actually, nowadays we are commonly seeing high risk patients, mostly aged, those who have high blood pressure, gestational hypertension, gestational diabetes. In that case, after 20 weeks, we commonly give calcium as well as some micronutrient like selenium, you have already said. NAD also, there is a role, and as an antioxidant, zinc also. So calcium allowing micronutrient is best choice.
Only for high risk patients.
Yeah, okay. But what I want to say is that what is the problem in obstetrics? That's an emergency obstetric care. That we cannot predict that this patient will land up in a eclamptic, what you have already said. In that case, if you give calcium along with micronutrient, it will not harm her.
Absolutely. I totally agree.
Yeah. So we are not expecting Bradley's ball. So if Bradley ball already started, then it will fall down. So in eclamptic patient,
You have to be careful.
yeah, that's the prevention is better than cure. That's why I at least from my side, I'll give calcium allowing micronutrient after 20 weeks onward.
So let's come to this case. We got this 19-year-old primary lady got admitted in the intensive care unit in Anita got with an episode of seizure 12 hours after delivering a girl child by cesarean section on the 37th week of her pregnancy. She was already suffering from gestational hypertension. She was already on Nicardia. She was suffering from other symptoms like blood innovation, headache. So I have included the baseline investigations which were almost normal. At the point of admission, she had a GCS of E3, B3 and 5. A medical management was started. She was started on antihypertensives, magnesium. So basically she was hemodynamically stable. She was talking to us. So we've already talked about the special consideration of nutrition requirements of this lady. So when do we suggest we initiate nutrition? She has already delivered, she is talking to us, maybe a bit of tunnel, being mostly a post-ictal state. So when do we, what do you suggest? When do you start initial nutrition?
As you have already said that the patient is taking food. So in that case, our motto is there is a two part. One is macronutrient, another is micronutrient. In macronutrient part, that energy, calorie intake, protein intake will be high, and fat will be low, and carbohydrate also low. Low carb diet, low fat diet, but high protein diet. And in micronutrient, that I have already said that zinc, selenium, this type of all micronutrients along with calcium we should prescribe because it's a case of pre-eclampsia. That eclampsia have already not started, so finger will cross that this will not happen. So we should start along with this.
Right.
And work.
So what calorie requirement? What I understand is it's a bit higher than the 25 to 30 kilocalorie per kg that we prescribe to normal patients. We have talked about this. So we generally have a target around 30 to 35 kilocalorie per kg. And we have a protein goal of around 1.5 to 2 gram per kg. Right? So, enteral or parental, I think we have talked about it, we'll prefer an enteral route. So, macronutrient goals, I think Madam has talked about, we'll just skip this bit. Micronutrient sir, we have talked about this, thank you for that. So, how do we monitor tolerance and adequacy? So, she's already in a critical care unit. In a critical care unit, what we do is we look for symptoms of gastroparesis, intestinal paresis, if the patient is vomiting, having diarrhea, is intolerant to feeds. We check for gastric residual volume. However, there was the famous REGAIN trial which showed that whether we monitored gastric residual volume or not, whether gastric residual volume is high or low, we saw in the Nutria trial, it doesn't really make much difference. We took an arbitrary cutoff of 500 ml, which was lower in some of other recommendations. We do all that in a critical care unit. Is there anything else we should be worried about? Because this patient is very high on progesterone, there is intestinal paresis, the stomach and intestinal contents have already pushed up a bit. She has higher chance of regurgitation maybe. So, do we need to be secure? What do you do in our regular clinical practice? Do we go a bit lower on feeds or we are...
No need.
Okay.
If I did a cesarean section, then after 12 hours, we'll start liquid diet. After 24 hours, absolutely normal diet. Not soft diet, not anything, direct normal
And
diet.
we'll stick to our usual calorie rules.
Yeah, normal diet.
Fantastic, thank you. So, this is what happened. 36 hours post-admission, her sensorium had worsened. She had got 2 more episodes of seizure. She had to be intubated because of the altered sensorium. Her ALT and AST has now gone high, LDH has gone high. Peripheral smear is showing evidence of hemolysis, where she is going into a hell. And now she is a real critical care patient. Yes.
That's a Mullary number.
So, what will be the special considerations for our nutrition now? Because now she cannot take it orally. We will need a nasogastric or a post-pyloric feeding. However, post-pyloric feed is not that great for pregnant patients. We need a nasogastric tube. And we'll stick to the... Yes, sir, go ahead.
See, what in this case, first we have to stop the feed. That eclamptic feed we have to stop. So that we have to give Maxal.
Yes, we have started on Maxal.
So, nutrition part is later on. First we have to stabilize the patient. We have to stop the feed. We have to check whether magnesium toxicity is happening or not. In that case, papular reflex, urine output, so you have to first stabilize the patient, then we think across next day morning, we see that no other feed can happen, then we think about protein, what I have to give, carbohydrate, fat and everything.
Absolutely.
First we have to stabilize the patient, otherwise
We are in a deep term, I understand that. But, sir, I'd just like to interject. What happens in critical care units is we tend to skip feeds. Patient is they're planning for a surgery, they're planning for intubation, they're planning for some radiological intervention. And there are numerous trials which have shown that these are the things which worsen outcome nutritionally. We are skipping feeds, even small feeds. And that in the long term gives a calorie deficit. Yes, we can be only giving feed to a patient who is actually seizing, but then if it is a critical care unit, we can start it in the night and not wait for the obstetrician to come in the morning. Okay, so if this patient starts bleeding, becomes very unstable, she goes on a NORAD infusion, say 5-6 ml per hour. So, what is the suggestion? We understand is even if a patient becomes very unstable, unless we have some features like the pH has gone very low, plus 7.2, the lactate has gone up really high, patient is on very high dose of vasopressors, the ASPEN guidelines do not really suggest cutting down the caloric intake. So, what do you do? What do you do? If you are in a unit where you probably don't have a very highly trained intensive care unit, so, and the patient becomes hormonally unstable, the patient is on NORAD, bleeding, maybe bleeding from the GI tract as well. So do you continue with the feeding or you skip to a parenteral?
No, in this case, it's a eclampsia along with HELLP syndrome.
Right.
That's why that platelet count is dropping and bleeding will happen. In that case, it's a definitely multidisciplinary tag.
Right.
We think about that hemolysis. In that case, we can give for temporary relief platelet, every and all. And we should check whether the bleeding is stopped. But in that case, platelet is only temporary.
Right, absolutely.
And in feeding case, we cannot think about this right now because that she is in big danger. She is going to HELLP syndrome. And we finger cross, we hope that her all parameters will improve time by time.
Okay. So yes, if she is suddenly unstable and she is having a major GI bleeding, perhaps we'll have to think of switching into a tropic feed, very low feed, 10 ml, 20 ml per hour. The Eden trial, the famous Eden trial. Anyway. So any role of adjuvants, anything else you would like to give? We have talked about selenium, we have talked about calcium, anything else, any vitamin, these patients, your pregnant critical ill patient, a patient who has gone to acute liver failure because of eclampsia or AFLP, will probably be having a deranged coagulopathy, the vitamins, the soluble vitamin levels will be going down. What is regularly practiced in a patient of acute liver failure, we give vitamin supplementations in vitamin B12, B complexes.
Vitamin B12 and all that.
So,
And one thing I want to highlight, not in this case, that in a gestational hypertension, we are first stopping salt. Don't intake salt.
Absolutely.
But it's a old theory. Now what we can say, you can take salt.
Okay.
That will not hamper you or anything.
Okay.
Previously it was thought that salt restricted diet. Nowadays it is nothing. She can take salt.
So what about the RAS activation, the renin-angiotensin system activation? We
No,
were
it will,
so worried about.
paper salt that it will not happen.
It doesn't happen.
It doesn't happen. It doesn't happen. She can take normal salt.
Okay.
We are not taking only salt. That she is also not taking only salt. But salt is not a hamper. In that case, what we had first felt that salt restricted diet and all this. No need to give any salt.
That paradigm
diet.
is-
Yeah,
that's great.
no need.
Thank you. Thank you so much. Thanks for your time. Thanks for the audience.